everybody. My name is Sylvain Rochon. I am the Paradise Engineer, and today I want to talk about healthcare. Not surprising, that's all we talk about these days: healthcare and the coronavirus, COVID-19, and what's going on around us. But I wanted to introduce another video. I did one recently about the opportunity this crisis is giving us to reevaluate our systems, to decide constructively to build something better. Out of crisis, we usually are um, more open to some unusual changes, to change the status quo, to do something, to try something out that may be uncomfortable or unusual or scary when we're not in crisis, because we want solutions. And healthcare is not, it's been a topic, and it's something that we really care about, especially now. So let's talk about it. Let's talk about it. Right now, we're in a crisis situation. The healthcare systems around the world, in particular, I'm going to talk about more Canada and the U.S. Both systems in a lot of cities are being overwhelmed. In particular, in the States, New York City is particularly impacted here. And we the countries have an excellent healthcare, not healthcare system, but excellent healthcare providers. Like, the people are tremendous, amazing, well educated. The best technologies are available to both, but the system is very different. In the States, it's private. In Canada, it's entirely public. So in Canada, we have a one-payer system with using the language used in the state, but I prefer universal healthcare, which is the same terminology and and type of system that I have in Europe, like UK, France, and even Russia, right? All OECD countries except the US has a universal healthcare system. And there's a good reason why a lot of these countries, including Canada, moved to that a long time ago. And it's because there was a decision made to ensure everybody would have access to healthcare. If you make it universal, you have taxes that pay for it. Everybody has access to it. It's a right for everybody. Now, the big argument in the States, like pre-COVID, right, is that, well, it would be too expensive to transition from a private system to a public system. We want to choose where we want to spend our money, where we want to have our services, and so on. And there's all the whole situation with insurances, because since you don't, in the States, they don't have universal health care. Different people can have different types of insurance that cost them more or less. Deductibles get involved in there, and different networks, different hospitals become available to different degrees, and so on and so forth. And I understand, the reluctance to lose that flexibility, that choice, but and this has been something that's been discussed by the proponents of universal health care in the presidential election process that's been going on for what seems to be 10 years now. But Bernie Sanders and some of the Andrew Yang and the others would say, well, universal health care, one payer system. It's you guys don't like change. It's like, to lose something psychologically is not desirable. So you want to keep the flexibility, but you want the safety of knowing that you will have a healthcare taken care of without having the humongous bills. So you want to have both worlds, but it's hard to achieve that. The easiest way to implement a healthcare for everybody is the universal kind, and it means a private system doesn't work inside that. But now that there's a crisis, it's an opportunity in the U.S. to reevaluate your guns, because it's all well and good to have choice, but right now there's a lot of people still don't have healthcare or inadequate healthcare, and a lot of people don't have a job. So I'm assuming, because I don't know all the cases, well, you're losing your work sponsored healthcare if you lose your job because of the virus or situations like it. All of a sudden, you catch the virus or you have some other problem, and now you have a humongous bill, and that's out of pocket for you. So there's this precariousness around certain situations like the current crisis, with a choice type of system where you get to buy. The big disadvantage that I see, and of course I'm Canadian, so I'm seeing it from the outside, and I'm really uncomfortable with the American system for this particular reason, is um, uh, I get, let's say I'm off because of a crisis like this, I don't have healthcare for a while, maybe I'll be fine. But then let's say in the intervening months, I get some kind of condition that make me undesirable for most insurances. Now there's, the Affordable Care Act and Medicaid and these other programs that can catch me, but it's not guaranteed. It depends on my specific situation, from my understanding. And then all of a sudden, I don't have health care anymore, and I have a condition. And I know this is the case for a lot of Americans, where there is a condition that already exists, and you definitely don't want to lose your health care coverage, because if you lose it, the company may not take you back because now you're at risk. These are insurance companies want to make money. Hospitals want to make money, so they want to increase the price as much as possible. Insurance companies don't want to insure you if you're at risk, or they'll crank up the premiums and the deductibles to kind of make their money back. Those that are most vulnerable are the people that get left out and that can't access reasonable health care at a reasonable cost. So that's what bothers me with it. And a lot of people could be comfortable with it, having people, not having any health care or having a $30,000 bill assigned to them because they got an appendicitis one day, which is not their fault, and then they're in debt for X number of years. It's a weird system, and it's terrible for people that are unfortunate, that don't make a lot of money. That the rich don't have a problem with it. They're fine. They can just pay if they can't get insurance. They can pay for it. So it's very elitist in my view. And I think the most important point, especially now, of why the U.S. should consider a universal healthcare system is because of this exact crisis, what's really happening now, which is a crisis that will cost, according to the White House, from I think yesterday or the day before, between 100 to 250,000 deaths just caused by COVID this year alone. These numbers are not going to be represented by other countries. It's very likely only the US is going to have that amplitude of numbers. Other countries per capita won't even get close to that. And the reason for that is because when the virus started appearing in China and then in Korea slowly, well, pretty quickly actually, that was in December, no one was motivated in the US to do anything about it. The government kind of did certain things to trace people that would come from these countries and track who if they were infected, and track where they were, if they infected other people, to do the contact tracing and sequestering of these individuals that would travel in from these nations, to prevent the spread and to try to avoid the community spread that happened eventually. While we started to try to understand what the virus, the characteristics of the virus, its, how it would spread, and so on and so on. So the government did some of that early on because that's their job. It's to take care of people, and The American government did do that. We did that also in Canada. Most nations did exactly that to kind of try to prevent the infection from traveling on a case by case basis, because there was no cases as far as we knew in Canada and in the U.S. for a while. And then when there was a time, there was the opportunity to do a lot more testing because there was possible community transmission. This is early January when there was like just a few confirmed cases in the States and in Europe, in each country. And then it became a bit more difficult. The government was trying to get some test kits, but hospitals were not incentivized or not interested to do any to participate in that effort at all, because they're running a business, a profitable business. And so the government and the CDC in the States were the only entities to kind of work on the solution, get some tests from Germany and other tests that would have some kind of value to do some testing. And it took a little bit of time, quite a bit of time, in the US for the government to rally the troops in the private sector, in the test labs, to get a lot of testing going. And it was weeks before it happened. Whereas in Canada and in Europe, like for example, Germany, they started testing countrywide early January because they have a universal healthcare system. It's all public. So the government said, well, okay, well, it's our system. It's the people's system. All the hospitals that can do it and all the labs that are associated, we're all pulling together to take care of that. So it's a much bigger system, but it is universal and public. But it could handle that load and start testing a lot more cases way, way, way sooner. And that allowed countries like Germany that currently have, no, I think it's nearly 80,000 cases confirmed. Let me check, because I didn't open that just now. And they've been testing to try to isolate as many people as possible. Yeah, it's 78,000 cases now. And they were able to isolate and track a lot more people and sequester the virus in different areas way, way sooner, because they could test countrywide much sooner and many more tests very, 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 very quickly. In the US, it took weeks. CDC has just a few labs and a little bit of capacity, and the tests, of course, the tests initially were not very they were not very good. There were flaws in the first ones, and then the one that was valid, the first one that was used that was valid, the results would only come in 6 to 7 days later. That's a technical issue, especially when you try to figure stuff out and try to get better tests. That takes time. But the whole country was not mobilized in the US. So the disease, because there was a lack of tracking, the disease was able to spread a lot more unbeknownst to a lot of people, because we were not tracking properly, and it's a big country. In Canada, we were able to do that a lot more because public health system. So every city was doing some tests and checking at the hospitals directly. Maybe this is coronavirus. Maybe this is doing some tests. In the States, the private hospitals had no tests of it because it happened so fast. They had no tests available, and they were not incentivized to do any testing unless a patient would come in with the symptoms, and they would have an insurance to pay for it. Because some of the reports of the initial COVID tests at some private hospitals would cost like $1,300. A lot of people don't have that money, so no, don't do the test, because that's money on my bill, and I don't want that. I don't have that money, or the insurance companies would not cover that test if you had insurance, because why are you doing the test? This virus is not on the dotted line for the insurance. So a lot of people went out of luck and out of luck and spent a lot of money, or just didn't do the test at all on them. So the whole system in the US failed this particular crisis because it's private, and because a spread of the virus like this is exponential, 2 to 3 two to three in scaling per generation. So every 3 to 4 days, we double or triple the amount of people that have the virus, because nobody was social distancing initially. Well, it was able to propagate kind of without any hindrance. And now we got huge numbers. Right now, I'm looking at the US compared to Germany, right? US, 213,000 people are confirmed with the virus currently. Germany, 920 deaths. So a lot of people confirmed because they started testing early. So that's the numbers that are confirmed. In the US, number of deaths, almost 5,000 now. 5 times the number of deaths in the US, and a little bit over 2 times confirmed cases. Now, the US have been ramping up testing recently because they got their shit together with the private hospitals and the CDC and FEMA. And over 1 million tests have been done over a very short amount of time. But Germany has tested more people. Their population is, I believe, it's somewhere around 80 million or something. Using that as an example, if you calculate the amount of people that were tested, okay, per million, I think there was, I read this this article that was like maybe 2 days ago. The US is like 32,000 tests per million citizens. In Korea, almost 6,000. In other countries like Italy, like 6,000 or 8,000 per million citizens. So yeah, they did fewer tests, but because they have fewer population, they sample a larger portion of their population to see if somebody has a virus. The US is wide, loads of population, 1 million tests. I mean, it gives good numbers, but you still have loads of people in the US that have the virus that are not being tested because there's so many people, right? So it's time to create a paradise, right? This is, we can rise from these ashes like a phoenix, like I said in my last video, by creating a better system that's able to handle these types of situations way better. In the case of the US, the prediction of I'm going to do a comparison, 100 to 250,000 people dying, and that's the silver lining scenario, by the way, according to the White House. Well, comparatively, Germany most likely will have like just 1/5 of that in deaths. That's how they're tracking. Even though, you know, well, 1/5, yeah, less than that actually. Because they've tested early, they were able to trap it. Korea is still at less than 10,000 cases, and they've kept their rhythm of testing 10 to 15,000 people a day. And they've got it under control really quick because public healthcare system, competent governance, and they have a culture of healthcare. And so they were able to trap it really quickly. And I mean, let me check Korea, because now they're down on the list. I mean, they used to be number 2 after China. They've suffered 165 deaths in South Korea. That's it. And by the time the US gets 250,000 deaths, or in thereabout, Korea probably won't reach 500 deaths. Well, actually, they probably will reach 500 to 1,000. But still, I mean, their population is not that small. They have about 8 times less population. If you do the math, 1,000 times 8, 8,000. Yeah, that's way less than 250,000 in the States. Okay. So the speed a nation can react to a crisis, especially a healthcare crisis, a response that requires a federal involvement, it's way faster if you have a public healthcare system. Now, if you're not convinced just because of crisis basis, because obviously we don't have crises like these every year or every couple of times a year. Thank goodness we don't. The the argument that the a privatized healthcare system is somehow cheaper is a complete myth. You can go to any valuable data site, a reliable data site, and you'll find that if you calculate all the costs, that includes public and private costs on a per capita basis. The US wins the race as far as cost per capita. So over $10,000 US a year per capita is what the average American pays in healthcare. $10,000, right? In Canada, my comparison is a little bit less than $5,000 a year. So yeah, we pay that through taxation, true. But when there's a pandemic going on, full mobilization immediate, and it costs us less from for the dollars, like from our wallets. Most European nations are somewhere between 8. Switzerland is like number 2 on the list. Like United States at 10,000. Switzerland costs them $8,000 per capita, and they have a universal healthcare system. Number 3 is 6,500, Luxembourg, and then it goes down 5,000. Germany, I mentioned earlier, 5,700 per capita. So the argument that it would be more expensive, no, it's not. And then there's the argument of quality. Well, quality is hard to gauge because doctors in the States are paid way more. So we think, well, probably the better doctors are attracted there because they can get the higher salary, perhaps. But if you look at another statistic, just the average life expectancy, okay? And again, just going to compare Canada to the US because we're brothers, very similar culturally in our habits, very, very similar cultures, but the healthcare system is a big difference, okay? Well, in Canada, the average the average life expectancy, for men is 80.3 years. So let's say 80 years. Okay, for women, 84. I'm rounding just to keep it simple. So 80 or 84. Okay, so the average between the two genders would be 82 years if you just average it out and you don't look at gender. Okay, so 82 years old in Canada. In the US, again, it's different healthcare system, but same culture generally, okay? In the US, man is 76 years and women is 81 years. Basically, you have a difference of 3 years between the two systems. Is it because, so the US, life expectancy in the US is 3 years lower? Is it because, on the contrary, the American healthcare system is of less quality? No, I don't think so. Like I said, you probably attract some of the better doctors just because of salary, right? No. The main reason why the life expectancy is lower in the US versus Canada is because a lot of people in the US, because it's expensive, healthcare is expensive. A lot of people in the US don't go to the hospital often enough when they have an actual problem, and they deal with it at home, but they have no money, or the insurance is too expensive, the deductible is too expensive, you don't use the hospitals, you don't do the services, but yet still pay twice as much as in Canada, especially if you're, on the lower rung and you're paying, you have a regular job, you have an insurance, and you're paying through the nose. You're paying more money, and your life expectancy is going to be on average 3 years less. So are you getting high quality healthcare? Well, I would argue that the wealthy, those that really don't care about the money because they're good, they just pay the healthcare insurance. They can choose the whatever hospital they want, and they get the best doctors. They're probably up top. They probably have a higher life expectancy, but that's not the average. That's just a small portion of the population in the US that have a high enough salary or great enough benefits to get that. And then if misfortune happens and they're off their insurance, all of a sudden they're just like everybody else. Maybe they can't pay it anymore and they can't afford to go to the hospital. They can't afford the ambulance. And so they'll lay it off. It won't go to hospital if they have a serious issue. And if they have something like the coronavirus, they won't go to the hospital either and just contaminate their whole neighborhood in the meantime because they can't afford it. It's a social dynamic that if self-damaging, it's too expensive. And then if you look at it from a global point of view, one nation that is highly contaminated contaminates the other nations. And the US will probably recover slower than other nations because we're behind the curve in the States. And because we're so proximal and trading so much in Canada, we're following the same curve, basically, just like fewer cases of the virus. Well, the other nations of the world that could have it licked faster, they have to wait for the US and Canada to catch up and have it under the control. Because otherwise, if we open trade to the US, to North America, while we don't have it under control and we don't have enough testing going on and we don't really track everybody, then they risk a resurgence of the virus in their own nation. So the world markets have to wait. We have to wait till all major nations that have spiked have it under control, and then we can increase trade and travel and get some of the economy up and back and running. So it'll take a long time for the world economy and individual nations' economy to really pick up, because we have to have all these nations coordinated and get things under control all at once. Because it's easy to get a resurgence. We're only going to get vaccines next year for this, and valuable tried and true treatments that doctors will be comfortable divvying out in hospitals. We may see some of that 2 weeks to a month from now at the earliest. Even though in the States, like the White House has said, well, okay, FDA, you can approve the chloroquine or hydroxychloroquine combined with azithromycin. A lot of doctors will not prescribe that because you need to know what the effect is. Is it going to be on the body of a person that is heavily infected with the coronavirus? And the data is not in for that. There's anecdotal tests that are not directly, tied to that were done, but not tied in as a full study to evaluate the safety of the virus. There was this French test that was done on 26 patients. I don't know, 2 weeks ago, or maybe a week ago, was published, and using these, the chloroquine and azithromycin, and out of these 26 patients. And I read the actual report, like the scientific report that was published, not from the news. 26 patients were given the medicine, or either the chloroquine and azithromycin. Okay, so either the combination or just one. 6 of and the attention from the doctor, a scientific approach. He wanted to see if those medicines would reduce the viral load compared to subjects that did not take those medicines. So there was a comparison, which is good science. That's what you want to do. And the test was for 10 weeks, and then it would see how much of the virus remains in the body, and then compare with the control group that didn't take any of the medicine. And it was a very good test, and it's encouraging results for that medicine. But the results were taken out of context by a lot of people in the media, and I'm assuming the White House as well, because the results were, like, if I just blurt out the results without the context, is that of those that finished the 10 weeks of taking the medicine, they all got a lot of very, very good results compared to the control. Like, in fact, those that took the combination drug, had no virus in their system at the end of the 10 weeks. Those that took the drug for 10 weeks. Those that took that one drug, only the chloroquine, they had 52% of them had no more virus at the end of 10 weeks. Great. The control was 12.5% of them had no viruses, and the rest still had viruses. So obviously these drugs have an impact, even though the sample size is very small. It's only 26 people that started the test. Now, there's a couple of things that the enthusiastic reports didn't talk about, not in the reports, but the news about this report, is that first, these patients were tracked for their levels, I believe it's sodium and other cases, because these medicines are actually can't be taken by anyone. They had to check and monitor them for certain levels, because these drugs are pretty heavy and they can have other impacts that could be harmful if you're not careful. So they were tracked. It's not a universal thing. It wouldn't be for everybody. And it was okay for all these 20 odd cases. Okay. And secondly, and most importantly, is that 6 of those 26 patients never finished the trial. So they were not counted in the statistics. Because the trial or the test for this report was, well, we're going to test for 10 weeks and see, what the percentage of virus is left in the body compared to the control group. Well, 6 of these people never finished. They essentially all left the trial at approximately day 3 for different reasons. One person died. Okay, he died. The report doesn't mention why. It could be out of complications because of the drugs themselves. We don't know. Could be because of the virus just overwhelming the person on its own, drugs notwithstanding. 3 of those 6 went to ICU and therefore could not continue the treatment because it was a test. It was not kind of doctors and hospitals doing, trying to treat the patient. It was an experiment, right? And when they went to the ICU, those 3 went to the ICU. The treatment was discontinued because then it became a different system, different nurses, different doctors, and they control the situation. And we know that right now, because there's no treatment, about half the people that go to ICU end up dying. So I don't know about these 3 specific patients that took the drugs for 3 days, but you can imagine 1 or 2 of them died based on statistics. The other 3, the other 2 that out of those 6 that didn't finish the trial, well, 2 of them were released. So they were fine. Okay, so even though they started a trial, the hospital said, well, no, go home, you're good, you don't have any virus in you anymore. So that was not necessarily, probably not caused by by the treatment being super fast. It was probably more because they had a very small viral load. They had a few symptoms, they went to the hospital, and then the immune system took care of it. That's the most likely scenario. So out of 26, you actually had 2 or 3 deaths, which is 10%. And 1 or 2 or 3 of those deaths could have been caused in part because of the medicine itself and some condition inside those people, right? Because sometimes you have reactions to strong medicine, and the virus is playing tricks on the body. So it's a great study. It's a start. We could show from that study that the combination in a certain amount of people or percentage of the population very likely will reduce the virus load. Yes, but it could have also some other side effects that could cause the symptoms to worsen, and we don't know because that study was not, the purpose of that study was not to test that. It was to test if it does reduce the viral load, and it seems to do that. So now what they're going to be doing is whether the next 2 to 3 weeks or maybe a month, they're trying as fast as possible to do large-scale testing to large groups of people, volunteers, I'm sure, and to see if those drugs cause some conflict with COVID, the disease with the virus itself, combination with other medicines and things like that, and how safe is that, so that to inform the doctors to prescribe that medicine to help reduce the virus. So this is very promising and it's great, but bottom line in my point is about the healthcare system, right? You need a universal healthcare system in the States so that you don't have so many patients when a crisis happens. And you get to spend half the amount of dollars that you would otherwise, and you would live longer on average. It's good, okay? So do that. Now, the other concern, and I'll end with this, with among Americans that are discussing this possibility of a universal healthcare, is that, well, that's going to blow up the government, because then it's managed by government, and government has a history of, you know, being not as efficient as private companies. But private companies is the bottom line, that's profitability. Yes, it can blow that up. But again, this is an opportunity not only to mimic Canada, which is fine, or the UK, or another universal healthcare system, but to make it a lot better. One of the main issues with doctors is that they have to spend half of their time, like literally 50% of their time, doing paperwork. Okay? So why don't we automate a lot of the bureaucracy or the paperwork for the doctors, so that doctors can spend twice as much time seeing patients? Well, that's a savings in money and capacity. The private healthcare system, in the case of the US, for example, well, there's a much smaller number of beds that are free in the system, because again, the purpose is to make money. So that you want to keep things tight. You don't have a lot of extra equipment, because it's really about the patient being able to be served. That's important, not having extra whatever in case. Well, in public healthcare systems, there's typically a lot more beds that are free in case there's a problem, because it's a little bit more slacky, right? Not managed as tightly as a privatized system. Well, in the case of a surge like COVID, well, that means there's free beds that are already freed up, because they just exist there for different occasions when there's an ups and downs, and there's more stockpiled equipment that are lying around, so you can handle a surge or a crisis way more readily. Whereas in a private system, then not only don't you have to incentivize the hospitals to do anything, they have to have a good reason money-wise. So, or it has to be forced by the government to do something, in invoking radical acts and laws from the past, from wartime and things like that. But I mean, you just you can handle a crisis, right? A lot better, and you don't need to scale up as much. And there's all these advantages, really. So yeah, again, to the opportunity, I was going there. You can automate a lot of the doctors' paperwork stuff. You could put on blockchain everybody's patient records, so it can be transferred to all sorts of doctors all the time through networks. And if you have a single payer system, a universal healthcare system, well, it's every hospital is part of the network, the same network, right? And so your case follows you around anywhere, everywhere, and it's all safe. It's all on the cloud in the distributed system. It's immutable. Only doctors can modify it, and everybody has access to read. And you have access to your own healthcare records if you want to look at them, and so on and so on. So automation, AI, we could create a healthcare system that does not bloat the government. You can have it run by the same hospitals as administrators, and kind of change the system in a different way, free up the doctors so they can see more patients, do a lot more telemedicine. Again, doctors, in different areas, different expertise. You don't need to travel to a different city to see the best doctor in that field. You can do a lot of telemedicine through the internet, and the doctor can see you very quickly, saves time, saves money, and there's a lot of things that can be done, revamping and make it way, way superior than the Canadian system, the Dutch system, the British system. America is where innovation is born. Why don't you do something, make it cheap, make it efficient, keep the high quality doctors, go ahead and go nuts, and that those doctors see more patients. Get rid of the insurance system for all this healthcare system. Do what most other countries do in the OECD. Like healthcare insurance is for dental and like regular dental, like stuff, and for your eyes and different things like that, because that's somewhat elective unless there's a major surgery that has to happen where your life is in danger. You're having your healthcare choices for that. That's fine. And then what we'd see in the States is that we'd avoid another situation like this, like COVID. You'd be like Germany when they started testing in January and have less than 1,000 deaths, like 700 and something I said before, and still tracking really well. Won't go anywhere near the quarter of a million cases where the U.S. is heading, because they got it under control really, really quick. You got to do this and get the other advantages of cheap, same quality, longer life expectancy. You just have to shuffle things around. It's going to be cheaper, and then you can still keep it small without increasing the bloat of the government through automation, telemedicine, all these things I mentioned before. Just get it done, guys. You can do it. It's time to innovate and improve on those systems. And then next year, the year after that, you got it made. You're fine. You don't need to worry about anything. Well, maybe a little bit. Ciao for now. Hope you liked it.